on this program committee because I get to invite my friends to come and speak, and I haven't seen our next speaker for 6 or 7 years probably, but we were on the AARC board of directors together, and we became very close friends through that time. And our next speaker is Kim Wiles, and Kim is currently the VP of Respiratory Services at Allegheny Health Network Home Medical Equipment, a very large regional home care company located in Pittsburgh, Pennsylvania. And her husband drove here to help save us money, but also because they've never been here, and so they're having a little holiday. She is another 35-year experience. Yeah, so we're all healthcare people. 25 of those were in home care. She is a past member of the AARC Board of Directors, Home Care Section Chair, and currently serves on the Position Statement Committee for the AARC. She is also a member of the Pennsylvania Society for Respiratory Care, Pennsylvania Association of Medical Suppliers, and serves on the Indiana University of Pennsylvania Respiratory Care Advisory Board. So please help me welcome my friend, Kim Wiles. Jason's going to stay. He's my hero.
Obviously, I always have to adjust the mic because you can even see me back there at the top of this thing. I'm used to walking because I'm so short. Anyway, so thank you, Pauline. Thank you, everyone on board for having me. It's always good to see friends. It's always good to see people again. I'm kind of with Joe. I'm so tired of doing Zoom meetings and it cuts out, and it's just nice to see people again. So thank you. So first, all right, let me just get. Okay, first of all, I have nothing to disclose. So a few of the objectives for today is we really want to look at some of the barriers that there is to caring for patients in the home. And I know Joe alluded to some of those, but there are so many barriers that exist, and part of that is because we don't have respiratory therapists in those places to help us with that transition. So we'll talk about that. We'll talk about the importance of communicating the care plan to all members of the post-acute care team so that we all can work together to get these patients home safely and effectively. And then really understand what are the gaps in the current reimbursement model. And as Joe stated earlier too, he talked about how respiratory therapists are not a covered service. So, unfortunately, when we get into the post-care arena, there are many instances where, respiratory therapists aren't involved. And I always say, I've been in home medical equipment for years, and I always say, we come with a rental of the equipment. How fun is that? We're part of the rental of the equipment. We're not there as a clinician, we're part of the rental. So it's very discouraging, but, we've come a little bit over the years, and I think we'll continue to move in the right direction, but we all just have to be engaged. So we'll talk a little bit about that. So the first thing is we really need to understand how we transition. I'm so used to moving, sorry, I gotta stand here so you can hear me.
Stand still.
I know, I can't, I'm hard. My arms go, anyway. Okay, so the first thing we want to talk about is transitioning patients from the hospital into the home. And sometimes that can be easy, and sometimes it can be a challenge. If it's an oxygen patient, it's usually easy, unless they're on 12 liters of oxygen and 75% oxygen, it's a little challenging. So that's when we really need to work with that team together. And we got to remember, we are all in this together. So we got to collaborate. It's chronic care. We have to understand chronic care. At some point, they're in an acute state, but whenever they go home, they're still in acute state sometimes, right? Because we're discharging patients a lot sooner. We have a lot sicker patients going home. I didn't see, how many are in home care here? Oh, a lot. Okay. So are some of you boomers? I'm going to use Joe's term. If you're boomers, have you seen sicker patients coming up? You know, we used to see 2-liter patients. Now we're seeing 12, 15, okay? So, and they want to send out higher than that. We've gotten orders higher than that, but we're going to talk about what are some of those obstacles to that care. But we really need to think of these disease states as chronic, and how do we all work together from the hospital side to the post-acute care side. So the first thing we need to do is really bridge that gap. And I think the number one thing for that is communication. Communication is really that handoff to that patient in the home. So whenever I worked in the hospital for a few years, when you're in a hospital and a patient comes in the emergency room and they go to the intensive care unit, what's the first thing they do? Give a report, talk about the patient. Patient goes to the floor after the intensive care unit, what do? Give a report. Patient goes home, goes to a skilled nursing facility, goes to an LTAC, what do? They tell us what the patient needs, okay? We don't get to hear what's going on a lot of times with that patient. I don't know, my neck of the woods we don't. It's kind of a blind transfer sometimes, not always, okay? Really need to understand the limitations in the home, because there are definitely limitations that sometimes the hospital caregivers don't understand, whether it be a respiratory therapist, a nurse, a physician, a case manager. They don't understand some of the obstacles that we face in the home. Is there family and caregiver support? And is that information communicated to that family and caregiver? Is there skilled nursing or facility available? Is it a high-risk respiratory patient discharging into the home without any support? Or is it a respiratory patient that's discharging into a skilled nursing facility without any respiratory support? And we'll talk a little bit more about that. Same thing with home health agencies. It's very rare that you see a respiratory therapist involved in a home health agency. It's physical therapy, occupational therapy, nurses, aides, speech pathologists, occupational therapists. Again, we're forgotten, okay? And we're so important in that transition. And then really identify and communicate any risk that's associated with that patient. I don't know about some of you in home care, but I see this all the time. We find out a patient's discharged and their oxygen is increased, but when we go to increase the oxygen, our service technician finds out that they were in the hospital because they caught themselves on fire, and they're burned. And they've been in a burn unit for 2 weeks. Okay? We never find out about that until we actually go into the home and see that. And that's something that needs to be communicated to those care members, that care team, so we can address that when we get into the home and know what we're getting into. So it's extremely important is communication. I also believe the respiratory therapist really needs to assume that discharge planning role. And I know in our area we now have what they call COP pathway, RTs, navigators, but they're really only following the COP patients. We do have pulmonary fibrosis patients, like Joe said, they're the loudest and they're the hardest to treat when they get into the home. But if we have a respiratory therapist in place, some of these obstacles will be understood and they can be fixed on the front end. So I don't know does anybody if it's in acute care, have respiratory therapists in the discharge role? One, okay, well, that's wonderful. I find it very frustrating when we get a patient who comes out, and I'll give you an example. We have a patient coming out 40% trach mask. Okay, we can handle that. But the patient also needs a lot of trach supplies, obviously, and when you ask what the trach size is, what do they tell you? A 4, an 8, okay? Well, that's not gonna help me, okay? And it's a 40% trach mask, and they tell me, oh, you need 8 liters per minute of oxygen. Not 40%, you need 8 liters. Well, how do you know it's 40%? And we'll talk a little bit more about that. But I think if we had a respiratory therapist in place that really could identify those needs and help, because we can't expect the discharge planners to understand that. we can't expect some of the respiratory therapists to even understand because they're not used to working in home care and they don't understand what we go through. So if we had a respiratory therapist at the helm that could address some of these things and really look at what's some risk identification, what's this patient at risk for when they go home, what medical equipment needs are they going to need, proactively look at what they're going to need to see if there are limitations and that they can actually go home. Is there a pulmonary rehab consult? Maybe it's a COPD patient that has been readmitted 4 times. Is there a consult for pulmonary rehab? If a respiratory therapist is involved, what are they going to consult? Pulmonary rehab. Okay. So, and they can also look. Is there a respiratory therapist in that skilled facility? If I discharge this 50% trach mask to that facility, is there going to be a respiratory therapist involved? Okay. One thing I know is Tennessee's pretty active with respiratory therapists in skilled nursing facilities. And one thing I can tell you is Pennsylvania is not. So it is a big gap in our state. So know your respiratory partners and understand what their limitations are and understand their skill sets. So, and I'll use that as an example as, DME companies, as we heard in the earlier lecture, they've been under fire, and it's really hard to maintain that level of service for these patients, being, the number of patients who've been getting in the home, unable to hire staff, the whole realm that we all experience. But we really need to understand if we have respiratory patients, are we sending them to the right arena? So the plan of care. So these patients always should have that individualized plan of care, and it should be communicated among everyone. Again, we plan ahead. If you have a respiratory therapist in the helm, we plan ahead. We know what's going on, okay? We follow up on required testing, because if anybody works in the hospital here, and I'm sure there are, and I don't know if you're part of getting the testing requirements for some of this equipment when patients go home, it's a nightmare, okay? So if you know ahead of time, you can arrange for those tests to be done, and we can get the patient the equipment they need. Participate in huddles. Participate in all the physician huddles, and you can hear what they're thinking, because the physician's famous for at like 4 o'clock on a Friday, oh, this patient needs a non-invasive ventilator. Okay? Think ahead. If you're involved in the huddles and you have a respiratory therapist involved, that respiratory therapist is going to think, okay, this patient's been in the hospital, they've been on a BiPAP, let's get the testing, let's do what we need to do to get this patient a BiPAP at home. And you can begin the education in the hospitals. Some of our hospitals, for trach patients, obviously, they will start education in the hospital, and they have to sign off on competency prior to that patient going home. But, we have had hospitals in our area that send a trach patient home blindly. And it's a real safety concern, and it ended up with a safety committee and an ethic committee, and we've gotten that changed in this one hospital. But that's because respiratory therapists really pushed that as well. The respiratory director said, I don't even know when a trach patient's going home. Well, and he didn't, but once he realized, and he was new to the system, once he realized what was going on, he has a respiratory therapist at the helm. Anytime that there's a respiratory patient involved, he gets that respiratory therapist there. So I think it is so key to really fight for that within your hospitals. Again, communicate. I'm probably going to say that 100 times today. Communicate that plan effectively. Does the patient have all of the home care things that they need, and do they understand? This should be, again, this should include the HMERT. Because if you're transitioning a high-tech patient into the home, wouldn't it be nice if we talk to each other? We're a profession. We should talk to each other and say, exactly what happened to this patient in the hospital and what we need to go home with and what can we do to help. And then implement that care plan. We started in some of our hospitals implementing care conferences. And these are really more for more complex patients. And, sometimes a non-invasive ventilator can be a complex patient. Okay, or sometimes, no, they're young, they're doing fine, we don't need a care conference. Obviously, invasive ventilators, always a care conference. So it really brings all the team members together to really discuss what those needs are going to be at home, the requirements. Barrier 2, meeting payer requirements. Oh my goodness, I've been in this field for, too long, and I can't tell you how this has progressed. It went from no requirements to the other end of the spectrum that requires everything to get these patients what they need, okay? So it is very frustrating from a respiratory therapist standpoint because we know what our patients need, right? But now we have to get it approved by somebody in the insurance field because maybe they just didn't meet this one requirement, then we can't set them up. So it can be very frustrating. I think that's one of the biggest obstacles we face. There's a lot of face-to-face documentation. We have to have required testing. There have to be written orders prior to delivery, which written orders prior to delivery, we've always had that, but there's a certain way that we have to write them now. The face-to-face has to be clear, documentation in the progress note, why this piece of equipment is needed for this patient. The testing has to be completed prior to the hospital, prior to the patient leaving the hospital. Discharge to a SNF or an LTAC, sometimes they don't have the ability to get the testing we need if they discharge from the SNF to home. So, for example, if a patient needs a BiPAP for discharge, if they go to a SNF, they don't really need any qualifications to get them a BiPAP at this SNF. But if they go home from the skilled nursing facility, now we need certain testing. They have to meet blood gas requirements. They have to meet, they have to have nocturnal pulse ox. There's a lot of things that go into that, so they have to have that testing. And most of the time in the skilled nursing and the LTAC, they don't have the ability to do those tests that we need. So if we can communicate that the patient is discharging temporarily to a skilled nursing facility, then we can get all that testing before they leave that skilled nursing so that we can be prepared for the patient to go home. So reimbursement challenges continue. We heard in the last lecture that we used to get a lot of money forever on patients. Did I think that was right? Yeah, probably not. You know, we got paid a lot of money forever. I'm using oxygen as an example right now. But they have decreased it so far that any of that extra service that we used to give, you just can't do it anymore. You know, I remember as the first respiratory therapist hired at a company, we did monthly visits for patients on oxygen. It was great. It was such, you know. Then it went to quarterly visits on those patients. And then it went to maybe yearly for some companies, and now it's non-existent, unless it's a trach patient or some higher end. But a standard oxygen patient does not see a respiratory therapist in the home. So there may be multiple providers in the home right now. So we just had a patient last week that we set him up on a non-invasive ventilator. We had no idea that they had oxygen in the home. They have oxygen in the home. They have a nebulizer in the home. So we're going in now with a non-invasive ventilator, and we didn't even know oxygen was existed, nor did we know it should be bled into the ventilator. So after multiple calls, we find out. But the reason for this is that 36-month cap, because Medicare and most insurances will only pay for oxygen for 36 months to one provider. So if a patient wants to leave after 24 months, then the new provider would only get paid for 12 months and have to take care of the patient for 2 years. So patients are really stuck once they get their oxygen provider, and every company has a different protocol. But on our company, if they're with another company for over a year, we can't take them on because we can't afford to service them. Because most of those patients want some of the higher end portable concentrators and things like that. So it's very disheartening for patients, because if they do get with a provider and they're not happy, it's very hard for them to find another provider. We have co-pays and higher deductibles that have to be met by patients. And we'll talk a little bit about more of that in my next lecture, but some of the reasons patients aren't compliant with care because of these high deductibles and co-pays. There's audits. The HME industry is under fire with audits. It's, prepay audits. We have to submit several patients, and they look at the documentation and say, okay, that's good, we'll pay you. Nope, you're missing something, sorry, we're not paying you. And you can't take you just service them for nothing, because you can't take the oxygen out of the home at that point, and you can bill the patient private pay, but most of these patients are on limited incomes. So payer models really need to change. We hear a lot about accountable care, and we hear a lot about pay for performance. We don't see a lot of it in our area in Pennsylvania. I don't know if you see a lot of it down here, but this is really key, because the funds can really be redirected to do best clinical outcomes. So don't pay me for a piece of equipment, pay me to manage that patient. And if the patient needs that piece of equipment, I'll give it to them without having to meet requirements. Let us, the profession, manage them. So, ultimately you get quality over quantity. So I think this is the future, and we will see that. It just takes time to evolve. So another barrier, so barrier 3, uncontrolled environment. So assessing the home really can uncover some things that we don't want to see, and can be a challenge. I see you smiling. So anybody in home care, we've seen the show Hoarders, right? Well, anybody in home care has seen that, right? Patient doesn't want you in the home most of the time. They want you to set it up on the porch. So, if we know this patient ahead of time is going home on a non-invasive ventilator, I want that to be communicated to me prior to the patient going home, because I want to see the patient's home before I set that very expensive piece of equipment in that home. So, oxygen, we have difficulty in some of these, there's nowhere to put it. We've had patients put it on the porch and run tubing in the house. We had one patient that put it in the neighbor's house and ran tubing across the window. We found that. It's amazing what you find, but if we don't see what the home looks like, and so I can't tell you how many times I get called from one of our service technicians when they get to the home, Kim, I don't know what to do. What am I supposed to do? The patient's already home, but there is nowhere to set this concentrator. So it really reveals some very interesting experiences when you get into some of these patients' homes. Fall risk. Tell me a hoarder's home isn't a fall risk. Okay, there is barely pathways. And when we deliver oxygen, the Joint Commission tells us we got to talk about evacuation plans. Oh, yeah. It's very tough. Throw rugs, lighting, electrical requirements, all of this. Then we get into fire safety, and I'm not talking every home is not a hoarder situation. You have some very beautiful homes and very well kept homes, but you have homes in our area, because we have a lot of rural Pennsylvania, and I'm sure that is here in Tennessee.
Here in Appalachia.
Yeah, Appalachia, where they don't have electricity, or they still have dirt floors. We still see that. So how do we deal with that when it comes to fire safety, and we try to educate those patients? And electrical safety. Sometimes patients will plug in one of these devices, and guess what? It won't work. It trips a breaker, if they have breakers. Okay, so those are the type of things, especially for that higher end respiratory patient, that we need to assess before they get into the home. Bathroom safety. How many times does a patient try to go into the bathroom and get a shower or not, because they can't. They don't have anything to hold on to. So when we go in as the eyes and ears of that physician and case manager to see, okay, doctor, I'm not calling you because I want to make more money on grab bars, because I don't make any money, but it's for the safety of the patient. So the respiratory therapist becomes that nurse, becomes that occupational therapist, becomes that service technician. We're all of it when we get in there. So we really need to see, what can we do to keep this home safe and keep this patient home safe and healthy. And then general, running water, no support system, pets. I had to go out at 1 o'clock in the morning last week because I had a respiratory therapist that had called off, so I just took call. And it was because the cat chewed her tubing for her non-invasive ventilator. So, 1 o'clock in the morning, it's not where you want to go, but, unfortunately it was a non-invasive ventilator, and how could I say, I'm sorry, you should have had an extra one? The cat, but it happens. It's real life situations. So we gotta make sure we understand what we're dealing with. And then the next barrier is patient challenges. This was a study by Pollock. It was a very small study, but he took 20 patients and caregivers just prior to and just after discharge on their home care needs. And the top 3 things that they found that patients and caregivers challenged with is knowledge. So you have a low health literacy of some of these patients. So, when we develop tools and education pieces, we really need to devise them on a 5th and 6th grade level, and sometimes even lower than it. So there is a health literacy issue, a lack of understanding. Resources. Some of these patients are going home and they have no caregivers. They have no baby boomer son or daughter. So it is very difficult to try to train patients. And for us, for ventilators, we want a second caregiver. You have to have a second caregiver that understands the equipment and understands what we're doing with the plan of care. And then self-efficacy and confidence, and really to, establish achievable goals for these patients. So, and how can we forget then non-compliant with care, okay? So once you get the patient all stabilized in the hospital and we take them home, and we go in as a respiratory therapist and we educate them and we tell them this is what their prescription is this is how they're to follow it, how many follow it? How many follow it? Now luckily, it is difficult to monitor, but technology is improving for monitoring. So, we can see what patients are doing on ventilators and CPAP and BiPAP and some oxygen devices now. We have some of our portable concentrators that do have technology built into them that we can see if they've ever turned it on. Can I tell you how many patients we have to call after a month because they've never turned on their portable concentrator? A lot. So as a company, we're billing that portable oxygen concentrator, but the patient's never using it. Ventilators, non-invasive ventilators. I'm billing that patient's non-invasive ventilator, and I look at his data in our compliance data, and I see he hasn't used it for 3 months. I can't bill for that piece of equipment because I'm now billing a piece of equipment the patient's not using. Does the doctor want to discontinue it? No, because it's a liability. So now we have to go after private pay, or we pick up against medical advice. So, we have to get these patients compliant and understand why they need the equipment, but again, that comes from all angles. So now that patient gets readmitted, and now we got to start the conversation internally about, are you following your treatment plan? Are you using your NIV? Are you, in many cases they'll say, no, I don't like that mask, and the DME company never called me, didn't come out to see me. How many times do we hear that? So, it's really difficult, but it is something that is key and very important. I don't know if I'll see it in my lifetime, in my career, but I think there will be a point where we will have to monitor oxygen compliance. Again, I hope I don't see it in my lifetime, but I really look at some point, and also with NIV. Right now, non-invasive ventilators, they're not asking for compliance reports, but at some point, I know they will. We have physicians asking, but. Okay, so pathways to compliance, they're starting to unfold. We have telehealth monitoring. That came with the advent of COVID. I think in home care we wanted to do it, but we just never did it. And with the advent of COVID, it allowed us, our company does a lot of telehealth with CPAP setups and basic CPAP setups. So that has allowed us to pull in the therapist and try to save resources with them traveling so much. Integration of different resources, so EMRs, sleep labs, payers, and so on. So a lot of, we use, I'm sure most of, I know home care you've heard of this, so we have AirView in ResMed CPAP devices and BiPAPs. So we can integrate that information into some of the EMRs and some of the EMRs within the hospital. So within our hospitals, the physician can pull it up at any given point and look at the report and see what the patient's doing. Okay, so they're starting to integrate a lot of these specific EMRs. Our biggest thing now, we'd like to see them integrated into, we have Epic, and we'd love to see this all integrated into that so that they don't have to go into multiple systems. So at some point, I think. And then it really empowers the RTs to effectively monitor those patients, because we have a whole team that sits internally and just looks at compliance and calls patients and sees if they're using it. And the same thing with non-invasive ventilation. It allows those respiratory therapists to be empowered to look to see, what is this patient doing? Do I need to change tidal volumes or max pressures? And we can actually remotely monitor them. So, we've used this a lot in our skilled nursing facilities where we will set them up on a non-invasive ventilator. They'll rent it from us. But we, the respiratory therapists from afar, will monitor and see if we need to make any changes in data. Okay? So barrier 5, equipment, and really understanding the limitations of the equipment. So first thing is, as I talked about, we really need to identify those needs. What HME needs are there for those patients? Oxygen is, a lot of these patients for portability are using pulse dose versus continuous flow. And in my next lecture, we'll talk a little bit more about that. The flow range, we have systems that we can wire together. There's certain concentrators that are deemed by the manufacturer that you can wire together to get flows up to 20. Because we have 10-liter concentrators, we have 5. If you wire them together, you can get 20. but we have a tubing, won't accept any tubing higher, or oxygen any higher than 15. So we can't deliver anything other than 15. That is the highest, okay? The pulmonary fibrosis patients can come out on 15 liters or 14 liters. And we'll see, and we'll talk again in my next lecture, how, there really isn't any portability for those patients that are 15 liters, okay? So you have tubing restrictions. Portable systems are extremely limited when flows are greater than 4. All these patients want these portable concentrators, and they're on 6 liters per minute. The portable concentrators will not maintain their saturations. So all the commercials, and again, we'll talk about that in my next slot or next presentation. But we see these advertisements, but they're not for everybody, and it's especially those pulmonary fibrosis patients. Ventilator backups. So you have invasive ventilators going into the home. It's a best practice to put a second ventilator in if you're further than a 2-hour radius, but we don't get paid for that. If it's a baby or an infant, you may. In most cases, you do. But if it's an adult, you don't get paid for that. So you're putting it in there free. And it's a pretty expensive piece of equipment to put in free, but it's still for the safety of the patient, okay? High flow systems. In the hospital, we connect a nebulizer bottle up to a 50 psi source, dial in the flow, and we get 50%, 60%. In the home, we don't have that luxury. We don't have piped in oxygen. If we use a 50 psi source through a cylinder, how long is that cylinder going to last? If we put an H cylinder in there, even that, we're going to have to go back every couple. You just can't do it. So everybody remember that air-O2 ratio question that we learned in school? Never thought you'd use it? Well, we use it because we have to reverse it. We reverse it. In other words, we connect it to an air compressor, one of those loud, horrible things. I will say, I'll give this a plug to Joe, I don't know where he's at. Drive has one that's much quieter than they used to be. But they're heavy. But we have to reverse it. So our max we can usually get is 40-45%. If you go any higher than that, you can't bleed in enough oxygen to meet the patient's peak inspiratory flow rate. So you are really limited. So when they call me and say, Kim, we have a 55% trach patient that's coming out, we can't do it. We have to go with 45%. It's amazing how 3 hours later, the patient's coming out on 45%, So very, but again, we need to communicate that early on so that we can do the testing and see if the patient really can tolerate it at home. So we can't accept liters per minute. We have to get a percentage, and like I said earlier, we get a case manager will call us and say, I have a trach patient coming out on 8 liters per minute. What's the percentage? So then she has to go back for respiratory. So if we were involved at the beginning, we wouldn't even have to make that extra call. Okay? So barrier 5, it continues. That reimbursement continues to haunt us, and it really creates gaps in the clinical care. Home health lacks RT expertise. A lot of skilled nursing facilities, they're unable to address pulmonary care due to limited RT expertise. Non-covered services, so they don't cover us in a home health agency, they don't cover us in the skilled nursing facility, they don't cover us in a home medical equipment company. You can see the AARC has a lot of work to do, and so do we as a group to provide outcomes, to show our benefit. So, new models of care for skilled nursing facility really allowed for some extra cushion to really pay for an RT if they want to. Unfortunately, in our area, they did the opposite. They got rid of the RTs. So, I didn't quite follow that, but anyway, it does create opportunity for us. And I'll go through a couple pilots that we have running in Pittsburgh, but we get the next slide here. So we do provide an RT support program to our skilled nursing facilities. What it is we have a contract with them, and there are various criteria in our contract, but if they need the support of a respiratory therapist as a consult, right now we're not doing, we'll leave you in that RT for 8 hours. We just can't do that at this point. We don't have enough staff as it is. But if they have a high-tech respiratory patient that they would like to admit, they'll get an RT consult from us. So we go in as a respiratory therapist, identify any additional needs they might have, do some education. What this contract also does for us is we provide education to the staff. So the nursing staff, the physical therapy staff, we talk to them on ADL activity and titrating oxygen. We do some education on trach care is our biggest hurdle in some of these skilled nursing facilities. So you shaking your head. So we do a lot of education. A lot of our skilled nursing facilities and also our home health agencies, I'm not taking a trilogy, non-invasive ventilator. Whenever we started with our RT consult program and they realized they could take these patients because we're monitoring the vent, all they have to do is hit a switch and put it on at night. We teach patients how to do this every day at home. They realize now that they can take some higher end patients. And we have one of our facilities now that are really considering hiring their own respiratory therapists. And that was really the goal of this program. The goal of this program was not to make money for Allegheny Health Network. The goal of this program was to get us out there and really, because it helps us in the end, because these patients eventually transition home, and so it helps us in the end. So, we provide admission, we talk to the patient, we see what they need, we work as a team with the group, we participate in their huddles, we provide direct patient care. Sometimes we don't, we had them call us one time and said, can you come in and do chest physical therapy every 4 hours? No, we can't, but we will train you how to do it. So if we can train you how to do it, you don't need us to come in. Again, it's not a moneymaker for us, it was a way to get our foot in the door and get them to know who we are and what we do. We talk about, we educate the staff on equipment, disease state management, we do competencies with the staff so we can sign them off. We do individualized patient education. We've worked with some of the families whenever they go home with non-invasive ventilator. And what's really nice about this program is it really, you see the continuity of care. So you see the hospitals discharging to the same skilled nursing facility that they know, and they can if it's in the patient's area, and then the patient goes home with that same respiratory therapist. So it's been a nice continuity of care for discharge. So we also identify additional care opportunities, medication administration, some secretion management, PAP therapy, ventilation management, because with home care, there's a lot of nice devices out there. I'll give you an example for secretion management. They don't have to do chest physical therapy every 4 hours. We can provide them with some vest therapy, some smart vest therapy. And, these facilities don't even know that exists because there's no respiratory presence. Okay? PAP therapy, we can identify some needs. This patient needs to go to have a sleep study, and treat while they're in there, obviously. And then ventilation management is a big one for us too. It has allowed these few facilities that we've got this contract with to actually provide ventilation. And then we have another program going, Pulmonary Rehab for our home health agency. So our system has an umbrella where it's healthcare at home, but underneath that umbrella sits home health, home infusion, home medical equipment, and hospice. So we teamed up with our physicians and our home health agency to put together a pulmonary rehab program for these patients. So we have a contract with our home health agency because they're technically a different company. But we have a contract with them. It's the same thing. They consult us for RT visits. And it's really part of this COPD pathway program that we have piloting, well, it's not piloting anymore, but that exists within our hospitals. So what our goal of this program is to show for home health, there is a benefit to us being here. We are also partially owned by a payer. So our goal is to go back to our payer and say, okay, we've shown that we have X amount of, we saved this amount of money, spent this amount of money, and this is your readmission rate. So we're not to the point where they're finalizing the data. This has been going on for almost a year now. We're supposed to get all of the data finalized because it's our home health agency that's pulling the data, and we will have data come January on the program. So we're really excited to see. But really what it's done is, we identified admission criteria. So the home health agency would only allow us to be part of the Medicare population, and that's because they get more payment for those patients, so they could absorb our costs. It was hard at first to get patients because there's so many Medicare HMOs, like Joe talked about, but we did get them. And then the physical therapist actually opens the case. They then consult an occupational therapist and a respiratory therapist, well, sometimes occupational, but respiratory therapist always. So we go in and we look at what is the patient doing, what are they on oxygen-wise, what are they using. We found patients using POCs that are on 5 liters per minute continuous, and they had this POC that they used to go out. So, or this patient's been readmitted 3 times. I think we need to think about non-invasive ventilation. What are the CO2s? And we look at all that. So, the outcomes are really, right now, being finalized, the readmission data. Communication definitely improved among the team. I can tell you, hands down, in fact, we've had some of our physical therapists request from their supervisor that they be present for all of our visits because they learned so much of the ones they just happened to be there. So that definitely has improved for sure. We do communicate with them. They call us on patients that aren't even on the pathway program because, they finally have that resource. We provide training and education to the care team too. So, we've provided in-services on portable oxygen concentrators so they do understand their limitations. Our home health agency wouldn't take a trilogy or non-invasive ventilator patient because it was a ventilator. So we've gotten rid of that stigma and now they do take ventilators in the home. So I think it has definitely improved, and from what they've told us, again, we haven't seen these numbers yet, so more to come on that, is the patient satisfaction has definitely improved. So I'm anxious to get those outcomes. So that is, the barrier to outcomes, it's essential to payment. We have to have those outcomes. If we don't go back to our payers with this, I can talk up here all you want how it's a benefit and the patients are satisfied, but if we don't have the data to prove that, we're not going to see any movement in the payer. So, we got to measure, we got to gather those outcomes, and we need to present those to our payers. So I just want to share real quick a case study that we had, and this was pretty recent. So we had a severe COPD patient that was on 10 liters per minute of oxygen, discharged to a skilled nursing facility without any RT services. So it was a standard, one of our standard skilled nursing facilities that just don't have any respiratory support. Critical patient without any respiratory support. Bi-level was used in the hospital, but not ordered for skilled nursing. The CO2 was 77. So they were using it in the hospital, but that information never went to the skilled nursing facility that the patient, and that's everything, that's a physician's fault, case management, but if respiratory therapy would have been involved in that discharge, we would have gotten that BiPAP. So critical treatment plan missed, not communicated. Day 2, the staff at the skilled nursing facility, the oxygen was increased to 12. So what they do, they turn the concentrator that only goes to 10 to 12. So what does it do? They always do that, they turn it beyond the 10, and now all of a sudden it's alarming. Okay, well, they weren't getting 12, they thought they were getting 12, so they changed, I didn't put this part, they changed concentrators because they thought there was something wrong with the concentrator. So lack of equipment knowledge, and they don't know, they don't understand, and that's what we're so key to get in there. Increased anxiety due to the concentrator alarming and the time it took to the staff to respond. Okay, so lack of patient confidence. The patient's now getting very anxious, the alarms are going, he's short of breath. Discharge note stated he was a high fall risk. So where do you think they put him in the skilled nursing facility? The back room, the farthest away from the nursing desk. Okay? So extremely low SAT level, 70%. He was having periods of confusion, lack of appropriate assessment, because we ended up having to go in because they wanted the patient on a non-rebreather mask and something else. So anyway, we went in and we said, no, this patient needs to go back to the hospital. After 4 days, patient was sent back to the hospital. And I didn't put in here, but the patient also did pass. So really a sad situation, and if, I keep going back to if maybe not, maybe we couldn't have saved his death, I don't know. But the poor man's anxiety and anxious level, just because there was missing that respiratory therapist. So, the questions to ponder on that. Who reviewed the plan of care? Was the RT included? I can probably answer that. No. Would this have happened if the RT was involved in the discharge process? No. Should this patient have gone to a skilled nursing facility without any respiratory support? No. Should the physician have a voice in the discharge placement? Should they? I think it should. Are they included in that? No. It is the discharge planner, and they're trying to place these patients near their home. I get it. But sometimes that's not sufficient for these patients. So, we really need to have those physicians voice an opinion. And I will tell you, in our facilities right now, they do have a voice. So, when it's a respiratory patient, and they have to approve the skilled nursing facilities, before the patients will go into those, unless the family really puts up a fuss and, they talk to them and explain why. But so again, hospital to post-acute, there is a broken link. We establish need in the hospitals. We do early intervention with NIV or long-term oxygen therapy. You have the RT support, and you get successful treatment, and then you discharge them. And now all of a sudden, if things break up, we don't have the testing we need. The documentation might not be adequate. The equipment might not be available, and the RT support might not be available. So, in summary, really minimizing the barriers to a successful transition of care is we gotta communicate. Communicate. I said that how many times today? Anybody start putting a little tab on their paper? More than 10. Communicate, okay? We have to know the payer requirements. Do we expect the acute care hospital to know all these payer requirements? Heck, we don't know them all in the home sometimes because they change daily. It just depends who's reading the claim and if they want to approve it or not. But if you have a general understanding, you have to understand what the home environment looks like. Would I expect a hospital RT to know that? No. But if the post-acute care team knows it and can review the home environment, they bring that information back. The equipment. Is the equipment available? Is there limitations? No, we can't do an 18 liter per minute patient. No, we can't do an 80% trach patient in the home. So, then you have non-covered clinical services that we just talked about. We don't have the RTs in the disciplines that we need, or in the facilities, in the skilled nursing, in the home health agencies, in the DME companies. So we really need to get those outcomes. We need to present those so that we can start getting paid for these services. We have our patient challenges. We all have that, and we talked about compliance. That is an issue with our patients sometimes, and we really have to communicate that back to the physician as well in the care team. So we have a responsibility in the post-acute care side too. It's, communicate. We need to communicate back. So if a patient isn't using something, we need to communicate that back to that facility. Because a lot of times, and it happens, we get a call from the physician and saying, the patient says he hasn't been using it. I wasn't notified. You picked it up against medical advice. Nobody told me. So, we have the responsibility to communicate as well. And I know you'll never be perfect in communication, but we definitely have to improve it. So, with that said, does anybody have any questions? Yeah. Yes.
Do you know if Florida still pays through their Medicaid program for respiratory therapists actually to treat patients in the home? Because they did, just before I left Florida, I know they did. I think there was a missed opportunity, but do you know, do they still do that?
I don't know that. Does anybody know that in here? Zach, do you know that? No? No, I don't know that.
I think that was a missed opportunity because I worked with Medicaid when I was in Florida and got Medicaid to pay for the therapy, for therapists to be in the home. And I know there were some companies who started doing that, but then I left Florida. And I don't know if that opportunity, because to me that was just an opening in the door.
Yeah.
And I don't know if that was ever followed up.
Yeah, I don't know that, but that's interesting because I think that's something we do need to look into, and are they? I don't know.
Any other questions for Kim? She's going to be around for a while. She gives another talk later, and is going to help Zach on his panel discussion after a while. So right now we have a half-an-hour break. Be back here at 10:30.
Hey, sorry.
I'm sorry.
Door prizes?
I'm sorry?
We're doing door prizes?
Yes, we're doing some door prizes in the exhibit hall, so come join us. And that's not the right time to come back. I don't have my
10 o'clock.
schedule.
10 o'clock.
You guys are so awesome. Thank you so much. Thank you for having me.
Thank you.
I'll fill my PowerPoint. If Caleb comes in here, I gotta go in the